Well, good morning, everybody. Let me start by thanking Dr. Sharma, Dr. Keeney, Dr. Bhatt. It's truly an honor to be here amongst such incredible leaders and luminaries in cardiology. So thank you very much. Okay. These are my disclosures. So number one, I wanted to start with PCSK9 inhibition. So this has been around. We've now had PCSK9 inhibitors for a decade in clinical practice, and it's truly been a triumph of bench to bedside and has been very useful in clinical practice, but we're still learning and still adopting PCSK9 inhibitors. The monoclonal antibodies are what we have had for the last decade, and these are data that have just emerged that I thought were really interesting, published in JACC by Kash Ray, along with Dr. Bhatt and Dr. Harrington, the whole Odyssey investigator team, showing earlier time to benefit with alirocumab in post-acute coronary syndrome patients in those that have elevated LPA. So what we see on the left-hand side here is that if your LPA is less than 50, the time to benefit was about 3 years. If it was 50 or more milligrams per deciliter, the time to benefit was closer to 1 year. So really a significant difference there. That level of 50 milligrams per deciliter, if you're using nanomole per liter units, would roughly be equivalent to the 125 nanomole risk threshold, which is a risk-enhancing factor in our guidelines. So I think these are further data that if someone has high LPA and they meet eligibility for PCSK9, we should be especially reaching for this class of therapy in them. And then the other key monoclonal antibody therapy that we have is evolocumab. And the latest kind of hot off the press announcement, the top line results are from the Vesalia CV trial. The unique aspect here is that these were individuals that did not have a history of cardiovascular events. They had coronary disease without MI, CVD, without a stroke, peripheral arterial disease, and advanced diabetes. They had LDL levels of a 90 at baseline, so 20 milligrams per deciliter higher than the prior Fourier trial. And so these are exciting results that we'll be learning more about at the upcoming AHA meeting in November. And then when we, looking beyond the monoclonal antibody therapies, we have the approach of silencing the PCSK9 gene with siRNA therapy, which is already into clinical practice with inclisiran. This turns off the production of PCSK9 in the liver. And what the unique aspect here is the frequency of injections every 6 months instead of every 2 weeks with monoclonal antibody therapy. And although we don't yet have the pivotal cardiovascular outcome trial data yet for inclisiran, we do have encouraging early data from the trials that have been completed to date. Sticking with the PCSK9 theme, but moving on to a totally different strategy with gene editing. And I wanted to acknowledge the progress that's being made by Verve Therapeutics. They're just acquired by Eli Lilly. Congratulations to Seth Katharison and the whole team. These are data from their Verve 101 product, which was used in 7 individuals, including one highlighted there who had a history of heterozygous familial hypercholesterolemia, had suffered a heart attack before the age of 30. You see the trend there with an LDL cholesterol reduction time averaged at 58% reduction over 2 years. So this is evidence that this is potentially a one and done strategy of injecting, getting base editing of your PCSK9 gene and having sustained LDL reduction. And then we have a number additional progress being made here with the Verve 102 compound. So this adds a GalNAc targeting glycan to avoid some of the off-target effects and is really what Verve is going to be moving forward with. And so here we see a 60% PCSK9 protein reduction as well as a more than 50% LDL reduction using this Verve 102 product. There's multiple companies in this space, so I can't go through all of them, but one other notable Nature Medicine paper just came out from Chroma showing an epigenetic editing approach where you use DNA methylation. So you're not cutting the DNA, but you're modifying its expression through DNA methylation. And so here, this was done in monkeys, whereas the Verve data are coming from humans, but in monkeys, really strong PCSK9 reduction as well as strong LDL reduction. So it'd be interesting to follow the multiple companies in this space because it really could be game-changing for the way we practice lipid management in the future. Meanwhile, something that is closer to getting to clinical practice than the gene editing therapies is Obicetrapib, or OB, which could be a really interesting comeback story for this class of CETP inhibitors where there's been 4 notable failures previously. Obicetrapib is being developed and the trials are being powered based on the LDL cholesterol lowering rather than the HDL raising property of CETP inhibitors, which is what was done with the prior drugs. Obicetrapib blocks cholesterol ester transfer protein. This blocks the transfer of cholesterol esters from HDL to LDL, but what's been also shown is that there's an upregulation of hepatic LDL receptors such that obicetrapib has a similar mechanism to what we see with statins and ezetimibe and PCSK9 inhibitors. I like to think of those LDL receptors as the garbage trucks of lipid metabolism, and so really that's the central way that we modify lipids, and OB having that mechanism makes it promising, I think, to ultimately show the cardiovascular outcome benefits. But what are the latest studies that we have with obicetrapib? So the Broadway trial was in patients with heterozygous FH as well as with atherosclerotic cardiovascular disease, showed a more than 33% reduction in LDL cholesterol levels and encouraging safety data. And then we have the fixed dose combination strategy shown in the Tandem trial. So here obicetrapib is being combined with ezetimibe, and you see on the lower blue curve here at the bottom a more than 45% LDL cholesterol reduction that's achieved with this combination therapy. So this is a similar strategy to what's already been taken with bempedoic acid and ezetimibe as a fixed dose combination. This 45% reduction is on par with what you would get with the combination bempedoic acid and ezetimibe, and on par with what you can get with the lower dose of alirocumab, as well as in the same ballpark as inclisiran. So this leads me then to number 4, that we're doubling down on the use of combination lipid-lowering therapy. And so this is a nice figure that came from the latest European guidelines that were released this summer at ESC. Our US guidelines are forthcoming in early next year. But what we're seeing is an embrace of combination lipid-lowering therapy. We had a non-statin consensus pathway from ACC that acknowledged the opportunity to use more combination lipid-lowering therapy. I think we'll see that cemented in the forthcoming US guidelines, and it's been shown here in the European guidelines. So we've really moved solidly from a time of focusing on statin monotherapy, where we could get upwards of a 50% or so LDL reduction, to now moving solidly beyond statin therapy for those patients who need multiple drugs to get to goal. We can get a 60 to 80% plus reduction in LDL cholesterol levels. This can be particularly helpful in patients who have trouble tolerating statin therapy, as well as patients that are just starting at really high levels, such as with familial hypercholesterolemia. So if you use a combination of high-intensity statin, ezetimibe, bempedoic acid, PCSK9, you can get an 86% or so reduction in LDL cholesterol levels. So I have a patient with homozygous FH who started with an LDL level close to 1,000, had an ileal bypass procedure at an early age. She's on that quadruple therapy plus evanicumab and has now an LDL in the 50s. So it's just incredible what we can achieve with modern combination lipid-lowering therapy. And related to this concept, number 5 is the traction with reducing long-term cumulative exposure to LDL. So we can go low, but along the lines of what Dr. Fuster spoke about so elegantly is the need to look earlier and to reduce risk factors earlier in life. And so we have genetic data that if you are lucky to be born with low LDL, and have lifelong lower LDL, the amount of risk reduction related to that is quite sizably bigger than you get with later introduction of lipid-lowering therapy, speaking to the importance of long-term cumulative reduction in LDL cholesterol levels. And then we have the data from the PCSK9 trial showing that we can drive LDL levels down to the lowest levels below 20 milligrams per deciliter, and it further reduces ASCVD risk, and it's completely safe. It does not cause increased diabetes, liver issues, cognitive issues. And in fact, that's been studied very carefully, the cognitive side of things. And in the long term, one can certainly think that doing this earlier in life could be beneficial from a brain standpoint. So all of this leads to the new paradigm, lower for longer is better. And so the data are there, but it's really a matter of implementing this in clinical practice. When we think about how to find people earlier in life, one new innovation is the PREVENT equations, which are starting to be adopted into US guidelines. They allow us to predict 10-year and 30-year risk, including it starting at younger individuals. It adds new risk factors like A1C, UACR. But we have to be careful about the way that new risk equations are implemented. So this was a recent paper in JAMA, and you see on the y-axis here, those who would be eligible for statin therapy, and on the x-axis, their 10-year risk. And so if we use the pooled cohort equation shown there in the bluish green color, that's with the pooled cohort equations compared to PREVENT there in the yellowish orange color. If you estimate using the existing risk threshold of 7.5%, there would be more than 10 million fewer people eligible for statin therapy using the new risk equations, because it gives a risk that's quite a bit lower. So we have to be really careful with the way that these are implemented, and I think you'll see that addressed in the forthcoming guidelines early next year. Beyond risk equations, we can measure single biomarkers like CRP, LDL, LPA. This is a paper from Paul Ridker and team teaching us that these, in healthy women over 30-year timeline, these individual biomarkers are complementary to each other in risk stratifying, so that could be used as motivation for earlier prevention. Sticking with the biomarker theme, and I know it's a talk about lipid management, but we use biomarkers to make clinical decisions about lipid management. Typically, we use LDL cholesterol levels, but there's been increasing interest around apolipoprotein B. ApoB is a complementary metric to use for clinical decision-making. This was a recent National Lipid Association statement that I was part of around ApoB, where we recommended a threshold or a treatment goal of 60 in relation to 55. You could simplify that just using 55, as I'll mention in a moment, for the as the equivalent LDL to an equivalent LDL 55 in those very high-risk patients. You can use 70 and 70, so 55 and 55, 70 and 70. I wouldn't recommend using an equivalent at the higher LDL threshold of 70. It doesn't, the higher LDL threshold of 100, it doesn't work as well in ApoB. It really should be around 80 or 90 at that point. This is a nice review paper from Anne-Marie Navarre and the UT Southwestern team depicting ApoB. There's one ApoB for every LDL and atherogenic particle. So you can think of it as a metric of LDL particles. The ApoB you can think of as kind of that stitching on the baseball wrapping around those LDL and atherogenic particles. They have this really nice figure in the paper showing that on treatment ApoB levels are similar to LDL levels, which really can lead to that justification for having an equivalent goal of 55 and 70. But again, it doesn't work as well at the 100 level. So when we look at the concordance of these across clinical categories in individuals in a large lipid database that we have, there really is quite a good amount of concordance, but there are people who have elevated ApoB that's discordantly elevated who have controlled LDL, and you could then thereby use ApoB as justification for further intensification. I don't think you need to check it every single time in all your patients, but you could do it once, and if it's discordantly elevated, it could lead to treatment intensification. Why I say to be careful about the 100 level is there's a large amount of people who would have an ApoB that's below 100, who have an LDL above 100, and I would be cautious to undertreat those people just based on ApoB. This is great data from one of our fellows, Allison Peng, who was formerly at Stanford, Hopkins now, is going to be presenting these data at AHA, and hopefully he'll have a simultaneous publication with that. LDL cholesterol still is the main metric we use to make decisions around lipid management. I want to just comment briefly, because this is a topic I've spent a lot of time on, around the accuracy of LDL equations. There's been more than 20 equations published in the literature. The classic equation is the Friedewald equation, but the Sampson NIH equation has been one of the newer innovations. And the latest paper to come out here is the modified Sampson equation. And this is a figure on the left here that shows LDL levels along the x-axis and bias compared to ultracentrifugation on the y-axis. And the modified Sampson equation is shown in red. So interestingly, the modified Sampson equation does solve some of the underestimation with the prior version of the Sampson equation at low LDL levels, but it has this kind of weird trajectory where it then overestimates, where it underestimates as you go higher. And we've now tested in our own data and find the modified Sampson equation actually overall performs worse than the original Sampson equation. You see my equation there in blue, and even in their data, you know, these are data where you're doing an internal validation based on equation they derived in that same data set. So even when you do an external validation of our equation shown in blue, it's performing quite well there with a bias close to zero across the range of LDL. So I still would, and I'm biased in this area, but would definitely encourage the use of our equation, which has been adopted by Quest and many other labs. Some labs have had a limitation of their IT systems to implement the original LDL equation we have. So for that reason, we've developed a machine learning version using a approach called MARS that allows for a transparent equation as a single line of code that can be then implemented in lab IT systems. So we're presenting that as well at AHA. It shows comparable accuracy to the original version of the equation, but could be more easily implemented by some labs. So be aware of where the LDL, how the LDL is being calculated by the lab by which you're getting. If you get it from Quest, it's going to be using my equation. If it's from LabCorp, it's going to be using the NIH Sampson equation. So there could be a little more underestimation from LabCorp. From other labs, it can be, and you know, it typically should be specified on the lipid lab report. And we also have a free smartphone app if you want to type in the total cholesterol, HDL, and triglycerides and calculate it yourself. We were actually playing around with that last night with somebody. Okay, so advance number 7 is the, and this ties in a bit with what Dr. Fuster was speaking around, where there's limitations of CAC, but when you get into middle age and older individuals, CAC can be a way to identify risk that wasn't previously appreciated. And there's been a lot of interest around the use of incidental CAC, which can be identified visually and qualitatively, or using AI tools to quantify CAC. A lot of the work here has come out of from Stanford. This is a nice review article that covers the opportunities here. And basically, if you have someone that doesn't have CAC, they can typically focus on lifestyle and not as intensive pharmaceutical strategies. Whereas once you start identifying CAC, you want to be more intensive around lipid management. So CAC is really, I think, helpful in lipid management for this reason, that can tell us how, you know, should we be setting the LDL goal lower. One of the key trials here using this strategy of incidental CAC. So these are CAC scores that are being found on non-gated CT scans. They were done for non-cardiology reasons. We're getting this information, it already exists, and now we're extracting this information and using it clinically. These were data from the Notify trial, which is led by Alex Sandhu and Fatima Rodriguez and the Stanford team. Interestingly, they showed that of those people who had this notification to their physician of incidental CAC, about half started on a statin. And I was really pleasantly surprised by the persistence. So they found when they looked out at 12 months and 18 months, it was 95 and 80% persistence on statin therapy. I was not expecting it to be that high, and they are seeing the LDL budge downward. So this is really encouraging, and I think there's an opportunity to then layer more strategies on top of this incidental CAC strategy. And of course, you'll be hearing more about imaging later. So I'm going to move on to digital health and implementation. I think this is really key, and I think, and of course ties in with some of the AI discussion earlier. It's just so shocking how much the mountain of evidence we have around lipid management and how little it still is getting implemented reliably in clinical practice. And I think that scaling up digital health paired with protocolized care and implementation strategies is going to be really key here. So we're talking about smartphone apps, wearables, AI. There's a wide spectrum of health applications here. This is a figure from an article I did for the 100th anniversary celebrations of AHA as part of the Centennial Circulation Series. And I think we're going to see AI and digital health impact every aspect of the patient journey, from primordial prevention to primary prevention to secondary prevention and long-term care. One example of this is the Cori Health Lipids program. That's something that's a homegrown app that we developed a decade ago and have iterated on since. It's been used in post-MI care, cardiac rehab, and now we have a lipid-focused implementation program, which is supported by the Lattice network, which is an implementation science network. And along the lines of what was mentioned earlier about kind of moving beyond death by pilots to implementing, the app is well developed. It's been used by many patients. We want to get up to 1,000 patients as fast as we can in an implementation science framework. So we're using the REAIM framework. So we're giving the app, it has animated educational videos that can engage and activate patients in their care. We're setting a rapid titration of combination lipid-lowering therapy to ideally get them to their goal within 6 weeks or certainly within 6 months. And so we'll see how this works. We want to get to 1,000 patients across 3 institutions as fast as we can, and then scale up hopefully more from there if things are working. As I get towards the end, advance number 9 is LPA. So of course, this could be a huge game changer in cardiology if this pans out in the cardiovascular outcome trials. We have the monoclonal antibody therapies already lower LPA 25%, but the drugs in development can lower LPA 80, 90+%, including siRNA therapies, small molecules, antisense oligonucleotides. So we're expecting next year the results from the Horizon trial of pelacarsen and then the results of olpasiran not long thereafter. So we're going to find out very soon the clinical benefit that can be realized with directed LPA lowering. As we await those results, I think we can use LPA as a risk enhancing factor. I showed you the data from Odyssey earlier that it leads to earlier time to benefit. We can drive down LDL and mitigate other risk factors. We can enroll patients in LPA RCTs, including now an RCT of those with subclinical atherosclerosis. And there's also something that I found about recently is the olpasiran expanded access program. I actually have a patient that just got approved for that and is going to get injected on Tuesday as part of that expanded access program. And then we can cascade test LPA in family members, including younger members in a family, and inspire prevention earlier. So as I get to the close, I wanted to then also acknowledge the shift from the sort of more the LDL focus to the triglyceride focus, where it's really fantastic to see the progress that's been made around pancreatitis reduction with ApoC3 inhibition. This is in familial chylomicronemia syndrome patients who started with triglyceride levels over 2,000. These were reduced significantly with olezarsen and nearly eliminated acute pancreatitis, really strong risk reduction. These 71% of the patients had pancreatitis in the past, and here the rate ratio was 0.12 with olezarsen. This has been approved for use in FCS. I've started using it in some of my patients, and it really is a valuable addition to clinical practice. And then there's other drugs in this area as well, including plozasiran, which has less frequent dosing given its siRNA strategy of targeting ApoC3, and has similarly shown an impressive reduction in triglycerides along with a strong risk reduction for pancreatitis with an odds ratio of 0.17. So this brings me to the end, my top 10. It was the PCSK9s and all the new data and experience we're learning there. Gene editing strategies, that could be a one and done strategy. OB as a potential comeback story for CETP inhibitors. The movement towards combination lipid-lowering therapy, because lower for longer is better. And to guide our lipid management, we have ApoB as an LDL particle measure. We can use incidental CAC, and you'll hear more, I suspect, this morning about broader use of CT imaging for atherosclerosis to guide prevention. There's digital health and implementation strategies that I think we're going to help scale up in our health systems to better implement all that we know. And then in the future, there's LPA therapy very closely to come into practice, and ApoC3 therapy, which is already in practice, and I think could have a much larger role in the future. So thank you very much. If I can just have one moment, I wanted to share these pictures of my sons from the ASPC meeting in Boston. They had a great time at the Boston Fire Museum. My son was still wearing that same shirt the next day when we were going down the elevator for breakfast, and we ran into none other than Dr. Deepak Bhatt, and my son got to show off his shirt and his badge to Dr. Bhatt. So thank you again for the invitation to be here. I'm looking forward to the rest of the day.
All right, yes, if you can pull up Dr. Budoff's presentation so we don't lose a minute here. But we will take some questions. There are thousands of folks online already, and so great to see the interest in the room and virtually. So let me start with this question saying, I request a direct LDL on all lipid measurements. This removes the problem with calculating LDL. Do you have any thoughts about direct LDL? I personally do measure it myself.
Yeah, that's another option. The gold standard is ultracentrifugation, which is something that we typically don't have access to in clinical practice. So the direct LDLs use proprietary chemicals to block the non-LDL lipoproteins to attempt to measure LDL. So there can be variability in how well they perform. They're not standardized by the CDC, but that is another metric you can use to assess LDL. But I would still highly recommend using the most accurate equations if you can.
Yeah, no, that's great advice. And it seems like you're a believer in ApoB
Yes.
as well. Great. If you've got a person in the highest quintile of LDL, Lp(a), and hsCRP, but with a CAC score, coronary calcium score of 0, would you still hold off on starting pharmacological therapy?
Not necessarily. So if someone has familial hypercholesterolemia, for example, with really high LDL, we're definitely going to treat regardless of a coronary calcium score. And it does depend on the age at which the coronary calcium score is done. As Dr. Fuster was pointing out, there can be limitations in doing a coronary calcium score at a younger person, so that would matter a lot. So the simple answer is I would say I might hold off, but in many people I still would not hold off, especially if the levels of the biomarkers were particularly high and it was a younger individual.
Yeah, I'm with you on that. I would, if the LDL were high enough, and there are additionally these other risk amplifiers like Lp(a) and hsCRP, I personally would still treat. And the final question here is how can we use pharmacogenetics to find the best lipid-lowering therapy for hyperlipidemia that does not respond to initial statins?
This is a really interesting question. There's been some attempt there actually in the CETP world. It didn't pan out. So I don't know. I think the short answer is I don't know about that one yet. But
yeah, no, I mean, I think it depends on evolving data, really. Here, for example, Mount Sinai, we're genotyping 1 million patients, not just in cardiology, that's throughout the hospital and health system, and we're up to, I think, about 400,000 or so. And, other health systems around the world are doing that sort of thing as well, maybe not quite on that scale. But I think when all the data are in, we might have an answer. It's a good question. We don't know right now. Well, fantastic. Really wonderful lecture. Thank you so much. So let us move on now